Hello, everybody. My name is Pascal Mosimann. I work as the Vise head in Essen at the Krupp Krankenhaus with the chapeau. I'm very pleased and happy for the invitation and to be able to speak to you today about some of the research I've been doing, mostly in Switzerland, actually, before I joined Essen. And so I'm going to talk to you today about vasospasm after aneurysmal subarachnoid hemorrhage and maybe a new potential therapeutic role for endovascular sympathectomy. So let's start with the problem. Usually, such as in this case, we get a pretty clear image of a subarachnoid hemorrhage with beginning hydrocephalus in this patient. Find a ruptured ACOM aneurysm, which is then coiled with balloon assistance. And then at day 6, the patient is still intubated, as we sometimes unfortunately see. And so we can't really follow them clinically. So we do some imaging, we do some perfusion studies. And we see in this case that we have some hyperperfusion on the left hemisphere. Bring the patient back to the angio and realize the patient does have vasospasm. So we go for balloon angioplasty. Usually we do a mix of balloon angioplasty and anti-calcic drugs. Some people have started now using stent retrievers. We haven't been very happy with these tools so far, but it seems to be in some other centers something that people like to do. So definitely, probably some interesting research also in that aspect. But anyway, in this case, we did an angioplasty and anti-calcic drugs. Had a nice result. The patient was still not clinically fit enough to be followed, and so again received some images, and then at day 11 we find this hyperperfusion, but this was already too late, and you can see that the patient already developed some infarct of the anterior cerebral artery on the left side, which unfortunately does happen in our practice, doesn't it? So vasospasm, delayed cerebral infarction, still remains a difficult problem and is difficult to predict and to treat in a timely fashion. So been trying to find other ways to maybe tackle this issue. Some people are working obviously on other possible causes of delayed cerebral infarction, meaning that vasospasm may be a marker and actually not necessarily the cause of all this, but this is another topic. So let's really get down to what vasospasm is thought to cause in these patients. So we know that around a week following the bleed, the vasospasms tend to occur, and we get this max like around a week later, which lasts for about 2 weeks. Most of the patients actually have more like andrographic vasospasm that is not necessarily clinically relevant, but still about a quarter of the patients, let's say, or a third of the patients do also have symptoms which are related to spasm and get treated. The risk and the severity of the vasospasm is obviously known now that it's proportional to the quantity of blood in the CSF space, so using the Fisher grades on imaging. And so where can we actually have an effect on this? We know there's autoregulation, and we know that we can either try to increase the blood pressure and so increase the let's say the transmural pressure through these means. We can also play with the respiration parameters and increase CO2 to get some vasodilatation. The other possible source of therapy could be or is trying to see how we can use drugs to actually stimulate or inhibit some of the markers or some of the markers that are responsible for the vasoconstriction response. And then there's also all the interactions with the different neurotransmitters that are released around the blood vessels. Basically, what is being done today, we still call that triple H therapy, but hemodilution is not done anymore, and also the hypervolemia is not necessarily also recommended by most of the intensive care teams. So basically, what most people do around the world now is just hypertensive therapy, really, right? Looking at the different drugs, there have been many tries to tackle this disease with drugs. Calcium channel blockers, magnesium sulfate, clazoxanthin, statins, milrinone, papaverine. So many drugs have been looked at. We'll come back to this also, I think, in the next slide. But basically, most of these or all of these drugs fail to reduce morbidity and mortality, even when vasospasm was seen to be reduced. So the only faint evidence that we have is that the intraarterial calcium channel blockers and balloon angioplasty seems to be the best way currently to tackle these spasms. So yeah, I mentioned the negative trials. So the Conscious 1 and 2 studies looking at clipped and coiled patients alike, using then the most potent drug that we found against vasospasm, which is clazoxanthin, an endothelin receptor antagonist, which is really effective angiographically when used. But unfortunately, as these trials showed, looking at week 12, there was on the extended Glasgow outcome scale no difference between patients treated with clazoxanthin or with the placebo, and an equal mortality rate in both groups. They did actually also discover or pinpoint that clazoxanthin has probably a very negative effect on the lungs and also on the blood pressure, and also causes anemia. So probably a lot of the benefits that are associated with this drug are counterbalanced by the negative side effects that it also induces. So this never came into practice as everybody was hoping at the time. And then talking about induced hypertension, there was also an interesting trial from the Himalaya group, trying to really study the benefit of induced hypertension for patients experiencing vasospasm and delayed cerebral ischemia. And this study was prematurely halted, as induced hypertension caused actually much more poorer outcome in this study. Although it has to be said, it was only a study where 40 patients had been included, so bit difficult to just make a general assumption that everything we've been doing and are still doing is wrong in these patients. But still, it's interesting to note that serious adverse events were about twice as more common in patients with induced hypertension than any other ones. And so I think it's worth mentioning anyway. And the status quo is currently still not good enough for these patients. Taking a little step further, we also know that subarachnoid hemorrhage doesn't just cause neurologic problems. We also know that it has an effect on the lungs and on the heart, and so you can have neurogenic pulmonary edema and cardiopulmonary impairment and infarction. And this is now known to be due to this catecholamine surge that is experienced by these patients, and then running through different cascades of events. You can then get these lung or heart complications, and also some microemboli, as you can see here in this slide. There was an interesting study in 2000 from Neuroradiology and colleagues, showing that there's increased sympathetic nervous activity in patients with subarachnoid hemorrhage. So they looked at the spillover of this noradrenaline in the peripheral blood, and so you can see on the first segment, these are healthy subjects, where obviously it's like control subjects. You don't see a big spillover of noradrenaline. Patients with unspecific pain do show a little increase in this noradrenaline spillover. But then when we look at subarachnoid hemorrhage patients between day 2 and day 10, you can see that they have massively increased sympathetic nervous activity expressed by this noradrenaline spillover, which then comes back to normal on the follow-up. So there was also a very interesting study by Yazargil and Peerless, pretty old study already, but they showed some extensive adrenergic innervation of the cerebral blood vessels. This was in the rabbits, but also shown to be true in humans. Showing this network of nervous fibers, which were here visible through fluorescence, showing catecholamine or noradrenaline on a pretty big surface area of the vessels, right? And then another study here by Edvinson and colleagues in the 80s showed that there was actually reduced noradrenaline uptake and retention in the cerebral vascular nerves associated with angiographically visible vasoconstriction in rabbits. And so you can see that this y-axis represents the size of the basilar artery dropping down at day 3 to 11, and then going back up to normal after about 3 weeks. And you can, well, what they showed is that the uptake of these fibers was extremely reduced in the phase of vasospasm, meaning that there was again overexpression of noradrenaline during this phase around the vessels. So let's take a schematic view of things. Basically, the innervation of the intracranial vessels is either, there's 3 basically, but so I'm not going to talk about the trigeminal fibers. They have a role in pain and migraine, and so it's also very interesting, but probably nothing so important to talk about right now. But there's either the parasympathetic stimulation or the sympathetic stimulation, which is basically the role of the superior cervical ganglion. We'll go over the anatomy in a minute. And so you can basically think that you can, well, physiologically, first of all, the role of the sympathetic system is to cause vasoconstriction, while the role of the parasympathetic stimulation, essentially from the sphenopalatine ganglion, is to cause vasodilatation. This plays a role, obviously, in autoregulation. And then you can think of either stimulating the parasympathetic system in case of vasospasm, or you can, well, again here, just to show you that you would stimulate here the sphenopalatine ganglion, and I'll go over a study in a few slides that has been studying this. Or you can obviously inhibit the sympathetic system, or try to inhibit the sympathetic system by targeting the superior cervical ganglion or the plexus around the carotid here. This was done in 2003 by a group in Geneva at the time, where they targeted the superior cervical ganglion. Let me show you a little drawing of a network to be more specific. Targeting this ganglion here around the C2, C3 region, where they actually could numb the ganglion, but due to the fact that it's local anesthesia, obviously the effects weren't that prolonged, and in patients experiencing this noradrenergic surge, this wasn't obviously enough to clear the problem. But still, they showed some effect of this numbing. We recently did also a study in patients who have so-called malignant vasospasms that you can't treat despite recurrent balloon therapy and or recurrent intraarterial drug therapy, where we targeted here the stellate ganglion, which is also known to have an effect on the brain vessels. And so we either percutaneously gave a shot while doing the vasospasm therapy to this to numb these ganglions on both sides usually, or occasionally left an indwelling catheter also to be able to repeat also this infusion of numbing substances to the ganglion, so local anesthesia repeatedly. We used roadmap guidance to avoid injuring the vessels, then targeted the sympathetic chain and give a little bit of contrast, as you can see here on the right side, or here on the left side, using the roadmaps to actually identify the ganglion and numb it. Published this like a few months ago, and showed that this might be interesting for some patients who are failing the conventional therapy that we use. So coming back to the innervation, this is also a nice work from, I can't remember the name of the author, but the Russians actually were very, very advanced in all the studies of brain vessels, and this is a Russian study. So I'm sorry, I can't remember the name of the author, but they did a beautiful work showing that there's bilateral innervation of the circle of Willis, basically from the fibers that we just talked about, very richly innervated, coming up the carotid arteries and then following the posterior communicating arteries to go also to the basilar, and also all around the ACOM and the beginning of the anterior cerebral arteries. So we thought it might be interesting to find a way to disconnect these fibers and see if this might have an effect on vasospasm. So working with a group of postdocs, we came up with a microelectrode system that you can apply around the spherocervical ganglion segment, with the aim of doing sympathetic denervation using radio frequency. And these are the two guys who have now founded Arteria Medicals, which are also working on other interesting devices. And so the concept is basically the same as the one used in renal denervation, where a probe is brought into the vessel, and then radio frequency energy is applied to injure the myelin sheath of the vessels in the adventitia, heating the adventitia to about 60 degrees using appropriate parameters, and we were able to show that this actually works quite well. So in rabbits, we had several groups to show that we did achieve denervation. So we had some lesions of the sympathetic nerves. We also took some rabbits where we did bilateral treatments to show that we had no side effects, meaning that we didn't hamper the blood-brain barrier, and so we had no ischemia, basically, no hemorrhage in the rabbits that were treated bilaterally with the therapy. As I said, we showed that we could denervate the sympathetic plexus that I just said, and probably the most important finding is that we showed that the rabbits receiving this bilateral therapy recovered faster from vasospasm than the others. This was done in eight animals in each group. And just again to show you that the aim of the therapy was this superior cervical ganglion, or even we were thinking about even going more distally to the just to the petrous and cavernous segment, to be even more specific on these fibers, but basically to really avoid the bulb and the unwanted reaction at the heart and lung levels. So to be very specific. So this is an example. I'm sorry about the quality of the images. When I reduced the size of the file, I think we lost a bit of quality, but I think it's good enough. Here in the group with no therapy, you see the baseline angiogram showing here the basilar artery. And then about an hour and a half after subarachnoid hemorrhage, which is done using autologous blood from the animal injected in the cisterna magna, you can see that there's still a significant vasospasm about an hour and a half after subarachnoid hemorrhage. And in the subjects or specimens where bilateral sympathectomy was done, this is the initial basilar artery diameter before suprachnoid hemorrhage. And you can see that an hour and a half after suprachnoid hemorrhage, it's almost actually normal. Looking at this in a different way, again, 100% here represents the nominal artery, the basilar artery. So you can see here, after applying blood in the cistern magna, you can see that in both groups. So this is the treated group in red, and in pink, this is the control group receiving no therapy. You can see that we do obtain, after about 20 minutes, when we look at the arteries, significant vasospasm with a reduction of the basilar artery caliber. About an hour later, you can see that in the treated subjects, there seems to be recovery, but you can also see that compared to the control groups, there's actually a pretty fast recovery too after an hour, meaning we don't see a significant difference between both. But after just 15 minutes later, so around an hour and 15 minutes, you can see that the significant margins don't overlap anymore, and so that we really see an effect of our therapy in the acute phase, which remains true also at 90 minutes. We didn't go beyond because we didn't have so much time and too much contrast for the rabbits. But you can clearly see that the recovery trend is much quicker and faster in the treated rabbits compared to the untreated ones, and such a small collective, it's actually very encouraging. Coming back now to the parasympathetic system, there was a very interesting study that came up in the Lancet already about 2 years ago now from Saver and other people, Molina. This Impact 24B study, and investigators tried to stimulate the parasympathetic system by implanting a little stimulating device at the sphenopalatine ganglion, and then did this in patients who could not receive TPA, and wanted to see if this had an effect on the infarct size, and if this could boost collaterals and stabilize the blood-brain barrier, which they did show. This is the implant. You can see that it was a small implant that they inserted as a bedside procedure in these patients, and then stimulated for about 24 hours. Again, they show that when there was low to mid intensity stimulation of this ganglion during 8 to 24 hours after onset, in patients who had cortical involvement, and again ineligible for IVTPA, they saw a 10% improvement beyond expectation compared to the sham group. And so if we take this concept and then also apply it to the sympathectomy patients or subjects, there's reason to believe that this might also improve the collateral flow and maybe reduce the infarct size, and so possibly could be of benefit in terms of delayed cerebral infarction also for patients. So basically, that's it. I didn't want to go too much into details. I just wanted to give you an overview of what we've been doing. But certainly, we've been able to show that vasospasm recovery is much faster after a sympathectomy using this endovascular device. There's a potential for collateral boost and blood barrier stabilization. So maybe we would have an effect on delayed cerebral ischemia. We still need to know if the delayed vasospasm subjects also profit from this therapy, because this was done at the acute phase. There's an issue about the delayed vasospasm models using animals, which is not as reliable as we would like to have. We get spasm in about 20% of subjects, which makes the planning of studies then pretty difficult, actually, because then you need a huge number of animals, and it's ethically quite difficult to do these studies. But we definitely need to prove the benefit of denervation in delayed vasospasm before we can go further with this therapy. But definitely it could play a preventive role, maybe at the time of endovascular treatment when we cure the aneurysm. We could think about applying the innovation at the same time, and maybe expect to have better results in the weeks following, meaning less vasospasm and less delayed cerebral ischemia. Obviously, this is an open-ended question. We know there is sympathetic nerve regrowth, which is also a reason why most of the renal denervation studies failed, which obviously in this case, or in the case of subarachnoid hemorrhage, would be a benefit to the patients, because then they would recover the full physiological function of their sympathetic system. So this would actually be quite nice. I guess we would have to prove this also, but we really feel that this is a very promising way to look at new options. And so that's what I wanted to share with you today. Unfortunately, I can't take any questions because this is recorded. This is all recorded, but you can certainly email me if you have interest in collaboration, or if you want to know more. And I'll be happy to answer any questions. And thank you again for the invitation, and have fun for the rest of the Congress. Bye. See you.